Next up, we have a relatively new member of the Wright State Orthopedic and Surgery and Sports Medicine group. An assistant professor with the Boonshoft School of Medicine is Dr. Indresh. He'll be discussing common fractures and dislocations of the upper extremity.
Hi. My talk is for a half an hour. I'll try to be as brief and descriptive as possible. Open for questions anytime. You can stop and ask me questions. So common fractures which I'm going to talk about is on a clavicle, humerus. I know Dr. Rubino already touched clavicle, so I just skip through that. And humerus, radius, ulnar, and some carpal bones if you have time. And some joint dislocations, sternoclavicular, acromioclavicular, shoulder and elbow. So starting off with dislocations, general rule for these are a few general rules for reducing a joint dislocation. Like we have to make a diagnosis of the dislocation, whether of any particular joint. Most of the times it is deformed when you compare it to the other side, and that is pretty obvious physically. But other things we need to check is the neurovascular status, whether any of the nerves have been compromised or is there any vascular deficit. Best way to do it, compare to the other side if you are in doubt or not able to come to a conclusion. And make sure patient has a good muscle relaxation. And for most joints, traction and counter traction helps as a good reduction tool. And we also have to make sure that we get radiographs before and after the dislocation is been reduced, because looking at the X-ray before reducing the joint helps a lot in applying the traction and also trying to maneuver, try to push the proximal or distal portion of the bone. It gives a rough idea and makes it more easier. And obviously we need to stabilize once the joint is reduced. And, so sternoclavicular joint dislocations, these anterior dislocations of the sternoclavicular joint is much more common than the posterior. But again, it is not very significant clinically as well. So most of the times we don't have to reduce this, or almost it's never possible to reduce this joint and hold it in reduced position, because it just falls back in the dislocated position. Right? Good news is they are not symptomatic all the time. They may have a bump which might bother, but function-wise they will not have any compromise. The most common mechanism is maybe in a motor vehicle collision where they have an anterior force to the shoulder joint. That's when the clavicle, there's a rotational force on the medial head of the clavicle, and the anterior portion of the joint is more weak, and so it just dislocates anteriorly. Sometimes even without trauma, it is also pretty common to see what we call as anterior atraumatic subluxation of the AC joint. So I think in this case we have to reassure the patient and just let them ensure that there is no good surgical technique to fix this and hold in position. So just may have to somehow come to an agreement to live with the bump, unfortunately. And for the posterior sternoclavicular dislocations, these can be real serious. Most of the times it is because of the anterior pressure on the medial end of clavicle, and it can be an emergency in the way that it can cause airway obstruction or cause damage to the major blood vessels. It can be either venous or arterial. So it is usually not recommended to reduce these fractures in an emergency room setting or in the office. If you're planning one, we have to make sure that there is a cardiothoracic surgeon backup if in case. If there is a major bleeding event, the patient can be taken down to the OR immediately. Patient might be stable, vital signs, everything stable. When you reduce the joint, it may dislodge the clot and may have a significant life-threatening bleeding event. See, the way to you may have to use a towel clip to hold the medial end of the clavicle, and as another person need to put some pressure on the anterior end of the shoulder and distract and try and pull it anteriorly. But it's better to do in a controlled environment than in the office setting, like as I said. And AC dislocations, I think Dr. Rubino went over this, so I'm going to skip through this. It's again, we don't have to reduce this. If you see them in the office, then based on the severity, you make a decision whether they need any surgical treatment or non-surgical. One, pointer. 1, 2, 3, pretty much can be treated non-surgically. 3 is a little controversial, where if patient is highly functioning athlete, or athlete, or participating in football or rugby, may need to be considered for surgical treatment. 4, 5, and 6 are severe, so that need surgical treatment. 4 might be a little tricky for diagnosis because in the AP view you can see in the AC joint in good alignment, but you have to take a outlet view or a axillary view where you can see the clavicle which is dislocated posteriorly. So that sometimes can be missed. And 5, 6 are significant, which need surgical treatment. And for shoulder dislocations, I'll go into the reduction techniques and also talk a few words about posterior and inferior shoulder dislocation. So anterior shoulder dislocation, which is common, seen in more than 90% of the patients. Here in elderly, it is more related to sports events, and in older individuals due to fall. And the mechanism is abduction, external rotation, and extension. This is the more common mechanism for dislocation of the shoulder. And once patient comes to the office, or when in the first presentation where they'll be holding the arm, typically they are externally rotated, and you can see loss of shoulder contour like this. See, it's pretty. See normal, and you can see this what we call it the sulcus sign. You can see the contour of the shoulder is lost, and again here. So reduction again, like these are the radiographs, normal, and you can see how this arc is disrupted here. It's pretty obvious. Okay, so different methods are described for reducing the anterior shoulder dislocation. Of this, the most common used in hospital setting is the traction counter traction method. This works for most of the time. I've almost always used this and has worked effectively for me. I have tried once or twice in my early days of practice when nobody was around for help. Believe me, I tried this. This works great as well. And it looks crude. It's called as the Hippocrates method of reducing the shoulder dislocation, especially when you're in a trekking trip with your colleague, with your friends, or somewhere outdoor, and if you find someone having a shoulder dislocation, this can be tried, and it works. Okay, so basically put the taking shoes off, stabilize. Basically, you're maintaining the counter traction with the foot, and just sustained traction is the main trick to this. You should not be impatient. Just give traction with the counter traction on the other side. Just sustain it for a brief period of time. Just if you hold it in that traction position for maybe less than 30 seconds or maybe a minute, it'll just go back in. If you just traction and just, oh, it did not go, and then release, then that's where, like, I get calls all the time from the ER. We tried 3 times, we could not get it in. So that's the clue. You go there and maintain the traction and just be patient, and it'll go back. The reason why this happens is you basically, by giving traction and counter traction, you're trying to relax the deltoid muscle. The deltoid muscle is in spasm, and it is preventing the joint to go back. So once you break the spasm by maintaining the traction, counter traction, once the muscle relaxes, the joint will take its position. And that's what they do here. Or sometimes if they are able to lie down prone, and if they don't let you put traction, you can hang the weights down. Here again, you're basically trying to relax the deltoid muscles, and once it relaxes, it just goes back in. And this method, some people describe saying that it is relatively pain-free, but I would caution doing this because since we apply torque type pressure on the humerus, there may be a good chance that you can fracture the humerus, especially if their bones are fragile. So the maneuver described is bring the arm to adduction, that is touching their side of the body, externally rotate, and bring the arm forward, and then internally rotate. That will put the shoulder back in place. And, so, posterior shoulder dislocations. These are very rare but very commonly missed. One of the most common cause for litigations in musculoskeletal related injuries is missed posterior dislocation, which can be easily diagnosed if we pay attention to clinical examination and one radiograph, which can pretty much diagnose 100% of the time, but we don't get that. So clinical exam, does anybody know what motion is limited in posterior shoulder dislocation? Is it internal or external rotation? Yeah, they cannot external rotate. When they show to the come to your office, they'll be keeping the arm by the side, and they say, my shoulder hurts. And we typically think, if we pay attention and ask them to externally rotate, and if you get a block to external rotation, that's pretty much clinically evident that they have a very high clinical suspicion for a posterior shoulder dislocation. So, and radiographs wise, it's very easy to miss posterior shoulder dislocation in just a plain AP and scapular view, because if you see here, it's see on this one here, sometimes this is pretty evident, but here you cannot say whether it's a posterior dislocation or not. And this is a scapular Y, but there is a sign what they call as a Mercedes-Benz sign. That means you should see the glenoid, and the humeral head should be sitting right on the center of that glenoid. But it's very difficult to get a typical scapular Y view to diagnose posterior dislocation. But the best view, which can almost 100% diagnose, is the axillary lateral. So many patients will not have this X-ray because you need to AB duct the arm, and or at least have the patient lean to the side and have the X-ray projected, which radiology techs are a little scary to do this because of the pain, and patient may not let them AB duct. But if we can get this view in the office, that will definitely diagnose posterior dislocation. And most often these dislocations are associated with tuberosity fractures as well, and that the stability can be assessed after reducing and see whether any further treatment is required or not. And, reduction maneuver is, like as I said, usually the deformity is in internal rotation, so they'll be holding the arm like this, and what we need to do is just a forward elevation and traction, and with some counter traction, and the person who is giving counter traction can put some anterior pressure on the humeral head, and it will just fall back in place. And posterior dislocations are also commonly seen in electrocution and in seizures. Do you know why? What's the reason? That's because of the violent contraction of the internal rotators of the shoulder. In our body, internal rotators are stronger than the external rotators of the shoulder. So when they have a convulsion or electrocution, the internal rotators contract so significantly that the joint dislocates posteriorly. And treatment, once you reduce this joint, the recommendation to immobilize is in about 15 to 20 degrees of external rotation. That can be achieved by this kind of a splint, what you call as a gunslinger's brace or splint, where you can, there is a post which sits by the side of the body and keep the arm in about 10 to 15 to 20 degrees of external rotation. And inferior shoulder dislocation. Has anybody seen inferior shoulder dislocations at all? In my 14 years of experience in orthopedics, I've seen one that was just about a year ago. And so it's very uncommon, but it can be really painful, and patients, sometimes it can be bilateral or unilateral. And the mechanism here is hyperabduction of the shoulder. When the shoulder goes into hyperabduction, the humeral head impinges against the acromion and dislocates inferiorly. And it's also called as luxatio erecti. It's another fancy name for it. And reduction-wise, again, like I said, traction, counter-traction works pretty good here. You can give some, here is the counter-traction and traction. Just maintain it for a while and it'll just reposition itself. And immobilizing is just a sling for comfort, because once it goes back in position, most of the times it is stable. And if you have any tuberosity fractures, that might need to be addressed to maintain stability. And so this is the lady which I was involved in. I was at Miami Valley Hospital, and this patient came to Miami Valley South ER, and I think he was 90-year-old, and was screaming, yelling, and in so much pain. And the ER physicians called and said it looks like it's a inferior dislocation, and we are transferring this patient over to Miami Valley Hospital Main for reduction. Then it would have been such a painful process for this lady to be transported. So I decided to go down to Miami Valley South ER and sedate. After getting good sedation, I was able to get it back in position. Basically what I did was I put a sheet around her shoulder here and have my colleagues pull some traction, counter traction, and I was holding her arm at the elbow, and just gentle traction, and with manipulation, maybe with 5 to 10 degrees of internal external rotation, maintaining the traction, I was able to get it back in. And this is how she looked after the shoulder was reduced. And her pain was definitely much better after this reduction. So you can come across this, but once we know exactly what to do, and as far as we are not causing any damage, that means basically it is a good chance that you can fracture or maybe cause some excessive traction to the neurovascular bundle. These are the two things which can go wrong. But excessive traction may be very rarely, because it's in the controlled environment, and you and your other colleague who is giving counter traction will be sensible enough to judge the traction required. And elbow dislocations. These constitute about 20% of all the dislocations we come across. And there are two theories. One is if the arm goes into hyperextension, the olecranon will just lever against the fossa and dislocates. And other mechanism is with a slightly flexed arm. If they fall because of the axial loading, it can dislocate the elbow. And most common is the posterior dislocation. Okay. So just to keep in mind, these are the normal landmarks you see. You see the congruent joint. This is the ulno-humeral joint, and this is the radiocapitellar joint, and need to be congruent. This is the dislocation. This is an anterior or posterior dislocation. Sometimes the residents, especially during intern year or med students, they have a doubt to how to diagnose, say whether it's anterior or posterior dislocation. Basically, anterior or posterior is in reference to the distal fragment. If the ulna is gone posteriorly, it's posterior dislocation. If it's anterior, anterior dislocation. Any joint for that matter. The bone distal to the joint, in whichever direction it has gone, is the direction of the dislocation. And so, look at this picture here. It can be real crazy. But there's only so much our body can take. If you try to overdo it, it'll give up at some point. So dislocation reduction maneuver is, you can either have them lie down prone by the edge of the bed and giving gentle traction to the forearm, and with another person trying to milk the tip of the olecranon, see, like it's been shown here, to jump it over against the trochlear bone. And it's very easy joint to reduce, and you don't need a whole lot of traction here. Sometimes if traction can fight against you if it is too excessive, because it will be blocking against the trochlea. So with gentle traction and at the same time simultaneous maneuvering, especially this force where you milk the olecranon again over the trochlea, it's pretty easy to get this joint reduced. Once it is reduced, for the most part it is stable unless you see some bony fragments on the X-ray. And one more thing we have to keep in mind is after you reduce or get the pay more attention to look at the post-reduction films. If the joint is incongruent, there can be a small bone fragments which can be incarcerated in the joint. So if you see any incongruence in the joint, it's better to get a CT scan and rule out there is no loose fragments in the joint. If there is one, that needs a surgical removal. Just like having a small stone in our shoes, it becomes so uncomfortable. You won't be comfortable till you get the stone out. It's so joint can be irritated, and there will be a lot of pain and may lead to cartilage damage if we let the loose fragments in the joint. And once it is reduced, elbow joint can get stiff very soon. So our goal is to get the elbow started to move as soon as possible, at least within the first 2 weeks. If you feel that it is unstable, then you can probably prescribe hinged elbow brace and have them start doing the elbow range of motion, which can give some stability to the elbow joint. And that's about it. And just a brief about metacarpophalangeal joint dislocations. It can be simple or complicated. In my opinion, the best way to diagnose is if you see a dimple in the volar aspect of the skin, that is most likely it could be a complex dislocation. If it is simple, then you may not find a dimple. What that means is, I'll show you in the next slides here. See, if it is a complex dislocation, the anterior capsule, the metacarpal head, it buttonholes through the anterior capsule, and it will prevent your reduction, and which at least 50% of the times may need a surgical reduction, where you may have to open up and take this capsule out of the way and reduce the joint. If it is simple, it's very easy to reduce. The maneuver is hyperextension. Just exaggerate the deformity of the joint and try to milk the proximal phalanx against the metacarpal head. And See, this is the way. Hyperextension and try to flex by maintaining that gentle traction. And again, here traction may not be your very good friend because it will fight. It will prevent the proximal phalanx to jump against the humeral, against the metacarpal. And once it is reduced, it need to be splinted in about 60-70 degrees of flexion at the metacarpophalangeal joint, and also wrist need to be maintained in about 20-30 degrees of extension. And maybe 6 weeks of immobilization and then start therapy after that, depending upon how stable you felt when you obtained the initial reduction. And phalangeal joints, again, it's basically you give gentle traction, and here it is more of maneuvering, where you try to place your hand over the proximal portion of the distal bone, that is the phalanx, and then try to lever it over the metacarpal or maybe the phalanx. So it can be volar or dorsal, and once you reduce, the immobilization depends upon the splint should go on the side of dislocation. This we have to keep in mind. If it for a dorsal dislocation, it has to be on the dorsal side, and in the volar dislocation, it has to be on the volar side. And again, if it is stable enough, some people even be aggressive and start moving them within 2 weeks. Some at the most maybe 3-4 weeks, but you can start moving the joints pretty soon because they are stable joints, and otherwise it can get stiff pretty soon. And coming to the fractures, just go over, like the initial evaluation and treatment of any fractures are obviously, once we know any part of any extremity which is deformed, we make a first initial examination, check whether it is open or closed, and is there any skin tenting, and check for neurovascular status, and also check for compartment pressure to rule out compartment syndrome. This is more of a clinical. Very rarely you may have to check the compartment pressures, especially when you have an unconscious patient or if they are not able to communicate well because of the head injury or maybe intoxication or any such situations. And radiographs obtained of the bone involved and the joint superior and inferior or proximal and distal to it to rule out any associated dislocations. And initial stabilization is basically you need to splint a joint proximal and distal and make sure the deformity is corrected. Say, for example, if it is radius ulna, if it is bent to 90 degree, that obviously need to be straightened by gently manipulating under sedation. Make it as straight as possible and splint a joint proximal and distal, and check for neurovascular status after manipulating, so that you know, to be sure that there is no compromise. And if you happen to see an open fracture, in previous days, the rule was to take the patients back to OR within 6 hours if there is an open fracture, because they have a higher risk for infection. But there are many studies which have shown that taking to the operating room within 6 hours versus within 24 hours or up to 48 hours doesn't make a significant difference. The only difference which they saw is administering antibiotics as soon as possible. So I would strongly recommend to start the first dose of antibiotic as soon as you diagnose an open fracture. For the most part, it's like second generation cephalosporins or like that's been the NSAF is the pretty commonly used antibiotic. If it is any form injuries or anything, you can add maybe any aminoglycosides or penicillin. Very rarely these days we use, but there is a small role for it as well. And I will skip over the clavicle because Dr. Rubino has already gone through that. And so one thing I need to tell about clavicle fractures is in the last 10-15 years, there is a move towards identifying these fractures which need a surgical treatment. Certain fractures, especially if you see this type of Z-shaped clavicle fracture, this is a good candidate for a surgical fixation because they do very poorly if treated non-surgically because of the pressure over the skin, and there is a less chance for this fracture to heal. So traditional treatment is like plate osteosynthesis. And coming back to the proximal humerus fractures, it's pretty common in elderly individuals. We have to make sure that you rule out dislocation. If there is a dislocation, again, if you're comfortable, you can definitely give one try to reduce the shoulder joint. If it is not possible, then refer to the treating physician as soon as possible so that they can take the patient to the operating room, reduce the joint and fix at the same time. If it is just a simple proximal humerus fracture, it can be stabilized just in sling for comfort, and no manipulation need to be done. But we also have to make sure that they have no axillary nerve injury. The best way to diagnose is check for a sensation in the lower half of the deltoid, what we call as a regimental badge sign. Where they have the military badge, that area patients have numbness if it is involving the axillary nerve. And the fracture is significantly comminuted and displaced, and if it is if depending upon what patients' requirements are, like if they are high demand and want to go back to work sooner and with good bone quality, then surgical indication gives good outcome. The standard treatment is using this locking plate with screws, which has a good success rate. And humerus shaft fractures. These are seen by direct fall on the outstretched hand, and it can be either comminuted or just transverse. And if you are able to get the fracture in good alignment, and if it is mid shaft, most of the times these fractures heal. But maintaining this alignment is a challenge. Sometimes we have to follow them closely, and if you see healing progress and if the splint is maintaining the alignment, then most of these fractures heal. In fact, studies have shown that the non-surgical treatment has over 90% chance of healing, which is almost nearly as near to surgical treatment. The splint what is applied for humerus shaft fractures is called the coaptation splint. That is a splint which goes around it starts here, it goes around the elbow and all the way up to the shoulder here. I'll show you in this view. Sorry. See here. It starts here, goes all the way around, and then sling for comfort. This coaptation splint can be maintained for about 3 weeks, and then you can take the coaptation splint and put in a functional humerus brace where it is short of the elbow joint. You can start moving the elbow and still protect the fracture and splinting it. If you leave the elbow immobilized for a longer period of time, more than 3 weeks, then that's the risk for stiffness. So we want to start moving the elbow sooner. And if a certain group of fractures, especially if it is significantly comminuted and involving this area, proximal third, those are the ones which are not very good healers with close treatment. They're most commonly treated with plate osteosynthesis, like as you see in the picture here. Distal humerus fractures it can be involving the joint or just extra-articular. But most of the times these fractures need surgical treatment. Initial stabilization wise, all they need is just a posterior splint and just make sure they have no neurovascular deficits due to injury, and refer to treating physician for surgical stabilization. And this is a typical posterior splint which goes around. You may or may not, if it is extra-articular, you can just stop the splint short of wrist joint. If it is intra-articular, it may be recommended to splint the wrist as well to give more support. And, treatment again is surgical for the most part, where you may have to fix on both sides as well. And radius ulnar shaft fractures. In adults especially, these fractures almost always need to be treated surgically, because if you see this interosseous space, if this space is narrowed because of the fracture fragments narrowing the space, then patients will have limitation of pronation and supination. That is a very difficult problem to treat if this fracture heals in this malposition. In fact, you may have to go and re-break and maintain this interosseous space. So that is the reason why we recommend to fix this to avoid shortening and also narrowing of this interosseous space. And initial stabilization is you can either put a sugar tongue splint, which I will show you in a picture here, like this, where it goes around the elbow and splint the wrist and the elbow, or you can just put a posterior splint all the way spanning the elbow and wrist. Also, we need to pay attention to see if there is any dislocations or not. It is not very uncommon to see dislocation along with fracture. This need to be reduced and splinted before sending to the treating physician. And these are treated again by plate osteosynthesis most of the time, and bone graft if they have significant bone loss. And this is the splint which I showed. And for the common material we need to keep handy to put a splint is, this is the stockinette. This is the first layer to be applied over the extremity. Followed by that will be this cast padding, and then either you can use a fiberglass splint or the plaster of Paris. This it comes in rolls or in sheets. You can the general recommendation is it should be at least 10 layers thick to give enough strength to the splint. And after applying, then just wrap it with the ACE wrap and make sure you don't put any finger indentations on it. All right. And this is the volar splint that we put. That's pretty much it. Any questions? Thank you.